Good evening, everyone, and welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, the Labor's International Union of North America. You'll know my name is Leslie Rattan, and I've been moderating our series. And you'll know if you've been here before, this is developed for individuals that have sustained concussions, their family, friends, as well as healthcare providers. And we've been running these sessions every other week on Tuesday evening at 6 o'clock. The sessions are also recorded, just so that you know. So if there are topics that you may have missed and are interested in, you can go to the Canadian Concussion Center website. I believe Christian will post the link in the chat. And there you can find recordings of all of our previous webinars. So just for this evening, if you do have any questions for our speaker tonight, you can please enter those into the Q&A. If you just scroll to the bottom of your screen, you'll see a Q&A. So if you can put any questions in there, we will get those answered in the second half of the webinar. If you're having any technical difficulties, please put those in the chat and Christian can help you out. Just before we proceed, we're going to run a quick poll. It's helpful for us to know who is actually in the audience. So Christian is just going to put that up. It'll just take a second, and then we'll get going. Great, thank you very much. So I'm really pleased this evening. We have Shaleen Sulway back with us. She was with us before, and Shaleen is a physiotherapist with over 20 years of clinical experience. Since 2010, she has been part of the multidisciplinary clinical team at the Hertz Clinic for Meniere's disease and vestibular dysfunction, located at the University Health Network. She works collaboratively with the team to assess and treat patients suffering from complex vestibular conditions. Shaleen also co-directs Vestibular Health, a physiotherapy clinic that operates within the Hertz Clinic at UHN and is solely dedicated to providing rehabilitation to patients with dizziness and balance disorders. She's completed her vestibular certification from Emory University and has advanced vestibular training from Duke University. Shaleen has a keen interest in teaching and research. She has taught vestibular rehabilitation at the University of Toronto School of Physiotherapy and School of Medicine, and has traveled across the globe to teach and present her research. Her latest research looked at the prevalence of vestibular issues in elderly patients experiencing falls. She has multiple publications in the field and recently published a chapter on the advances in vestibular rehabilitation. So with that, I'm going to turn it over to Shaleen.
Thank you very much, Leslie. And thank you very much to Dr. Tatter, who invited me back, and the Canadian Concussion Center as well. So today's topic is vestibular physiotherapy as a treatment for dizziness after concussions. So concussions can come with a multitude of symptoms. So if you're watching today and suffering symptoms after a concussion, or if you're a clinician that sees patients after a concussion, you can probably relate to some or all of these symptoms here. Symptoms of dizziness and balance and visual disturbances are quite common, and these can be often very difficult to understand and treat. So in the next 30 minutes or so, what I hope to cover is I want you to understand dizziness after concussions and its relation to the vestibular system. We'll review the anatomy of the vestibular system and then review some causes and symptoms of vestibular dysfunction. We'll talk about vestibular rehabilitation treatments for vertigo, imbalance, and visual motion sensitivity, and then review some barriers to recovery. And then the final 30 minutes, we'll open it up to some questions. So dizziness after concussions. Dizziness is the second most common symptom after a concussion, the first one being headache. Dizziness and vertigo can occur in up to 80% of concussions. And from a variety of different studies, we know that if dizziness is there early on, it's often linked to protracted recovery. So in one particular study that was done at the University of Pittsburgh Medical Center, they looked at 107 football athletes that had had a concussion and looked at over 11 different symptoms, ranging from loss of consciousness, amnesia, nausea, vomiting, confusion, visual issues, dizziness. And they found that dizziness at the time of injury was the only factor that predicted protracted outcomes, where it was taking longer than 21 days to get better. So dizziness, for those of you that have had it, is a very disabling symptom and an important symptom to have assessed and treated. So dizziness is the number one symptom when you have an inner ear injury. So if we take a look at what's inside your inner ear, what you will see, hopefully you can follow along with my cursor here, you'll see this structure. This is in your inner ear. The left part here, or the top part, is your balance organs, which makes up part of your vestibular system. And then this shell-like structure here, this is your cochlea, which is your hearing organ. So for the purposes of today's talk, we're going to focus just on these upper balance organs here. Now, the susceptibility of the inner ear to trauma is not surprising, since these balance organs are surrounded by the temporal bone and they are subject to forces on the head when you have a concussion. So let's take a look at the anatomy of the inner ear. So you've got three semicircular canals. There's the superior canal, the lateral canal, and the posterior canal. These canals are oriented at 90 degrees to one another, and they are fluid filled. So when we rotate our head in certain positions, fluid in these canals will move, and that's what gives us the perception of movement. So these three semicircular canals detect angular rotational movements of the head. Further back here, we have the utricle and the saccule. These are two gravity receptors that sense gravity and linear acceleration. So when I'm referring to gravity, this would be a feeling of falling on a roller coaster or standing in an elevator and the elevator drops. You feel that drop. Whereas the utricle, it will do linear acceleration. So if I'm sitting in a car and there's a lot of stop and go type movements, that's what I'd use my utricle to sense that. So when we use the word the vestibular system, well, what do we mean by that? Well, we are referring to these balance organs that we just reviewed in the inner ear. We're referring to this 8th cranial nerve, also known as the vestibular nerve, and then parts of the brain that process vestibular signals. So this is your brainstem and your cerebellum. And your vestibular system has three major functions. It's designed to help you maintain your posture and balance. Most of us don't realize, but it also controls our vision. It allows us to see clearly when our head is moving. So this is our Steadicam, or our gaze stabilization mechanism. And it gives us spatial orientation. So spatial orientation is the ability to regulate your body's movement through space and to be aware of that movement. So if these balance organs, the nerve, and the parts of the brain that receive these vestibular signals, these balance signals, are normal, then you will have normal balance, vision will be clear when you move, you won't have any disorientation or any kind of dizziness. So in a situation where you have a concussion, you can have trauma to the brain, which is caused by a concussion. This can result in abnormal functioning of any part of the vestibular system. So the brain can receive abnormal signals regarding spatial orientation, the movement and position of the head. It can get abnormal signals from the balance organs in the inner ear. It can get abnormal signals from the nerve, or the brain just may not be processing that information that's coming from the ear properly. So when the vestibular information is inaccurate, or it's asymmetric, it's different from side to side, or it's processed inaccurately, then the output will be inaccurate as well. And if you have inaccurate outputs coming out of this system, you will feel dizziness, vertigo, imbalance, and visual symptoms. So let's talk about each of those four symptoms in detail. Let's talk about dizziness and vertigo. These are not synonymous terms, so I'll define dizziness. Dizziness is a non-specific term. It can mean different things to different people. So if you come in to our clinic, either myself or our doctors will always say, well, if you can't use the word dizziness, what do you feel? And some of the words I've heard over the years are spinning, sense of lightheadedness, rocking, swaying, floating, or a sense of disequilibrium. So it varies. Vertigo, on the other hand, this is a very specific type of dizziness. This is the illusion that you or the environment is moving when you are not. Often there's a rotational or spinning component, but it doesn't have to be. It could be a tilting feeling, feeling as if like the room is on a tilt, or feeling like you're moving up and down or bobbing, a push or pull feeling, or a feeling of falling. Dizziness and vertigo, it can be triggered by changes in position. It can be triggered with movement, especially head movements, but it can also be spontaneous in onset. And each of these questions that we ask our patients about how it's triggered gives us clues into what could be causing the problem. We also know that dizziness and vertigo can last seconds in some cases, minutes with other conditions, hours, and in rare cases, it can be constant. Often, it comes with nausea and vomiting and a sense of unsteadiness. And there can be other symptoms as well, such as ringing in the ears, fullness, or hearing fluctuation or hearing change. Imbalance. This is a feeling of unsteadiness or disequilibrium that's accompanied by spatial disorientation. So I've heard this line many times, people must think I'm drunk. So imbalance comes with balance and gait disturbances. Usually it's worse with movement, especially head movement. It's more difficult to balance for patients in the dark, more difficult on uneven ground, and patients will generally say, I feel best if I am sitting still. Visual symptoms, these can take on two different forms. So one of the reflexes that comes out of your ears is called the vestibular ocular reflex. So if this reflex was affected because of a concussion, you would complain of oscillopsia. And what that is basically blurred vision or difficulty focusing your eyes when your head is moving. So patients will say, my eyes just don't keep up with my head. I feel like there's a bit of a lag, or the horizon is bobbing when I'm walking. So that's what you would see if you had a vestibular ocular reflex issue. You can also have intolerance to complex visual stimulation. So this is where patients will say, I feel dizzy when I move my eyes across a page, when I'm reading on screens, especially phones and computers. When I have to scroll, I get dizzy. When watching fast movements on TV, I'm dizzy. Driving, and malls and grocery stores, busy places can make them dizzy. So there's many different causes of dizziness, vertigo, and imbalance, and we usually like to break it up in two different ways. You can have peripheral vestibular causes, and that would be directly coming from your inner ear, or central vestibular causes. This is the processing part of the brain, the parts of the brain that process these vestibular signals. So we're not going to talk about all of these in a 30-minute talk, but the ones in red I am going to go over: benign paroxysmal positional vertigo, vestibular hypofunction, and in the central vestibular category, we'll talk about visual motion sensitivity. And I would say these are the three conditions that I would see most commonly in my practice. So benign paroxysmal positional vertigo, big mouthful, we usually refer to it as BPPV. This is the most common presentation of vertigo in adults with or without head injury. Under the age of 50, the most common cause is a head injury. Now, this is characterized by brief, recurrent episodes of vertigo. And when we say brief, the vertigo itself should be less than 60 seconds, typically on average between 15 and 30, what we see clinically. It is usually triggered by changes in head position relative to gravity. So bending forward, lying down, looking up, rolling over. These type of things will bring on the vertigo. It will not occur if you are just sitting with your head still and not moving. Often it's not just the vertigo that patients have. There's associated nausea, vomiting, imbalance, and that can linger much longer, hours or sometimes days after a vertigo spell. And the good news is it does respond quite well to treatment. So what happens with BPPV? Well, we've got our utricle here, and you can see this utricle has openings into all the semicircular canals. And if we look at the bottom here, inside the utricle, we don't have fluid like we do in the canals. Here we have hair cells. And on top of these hair cells is a jelly-like matrix. And on top of that are small calcium carbonate crystals. This is a normal part of the anatomy. Everyone has that. Now, what can happen with a concussive force or a deceleration force? These crystals that are sitting on this gelatinous matrix, they can break off. And now, once they are free-floating particles in the utricle, they are free to migrate into any one of these semicircular canals. So what will happen is now, if these crystals fall into the semicircular canals, now when you move your head, that will cause crystals in the fluid to move. That sends false signals to your brain, and that will trigger vertigo and imbalance. And until those crystals don't stop moving and settle in place, you continue to have vertigo. So the way we test for this is through the Dix-Hallpike maneuver. This is a standard test that we would do on any patient coming in with concussion. So we have them in picture A sitting upright on a bed. We turn the head 45 degrees to the side that we are testing, and then we briskly lower that head down so it's hanging off the edge of the bed 30 degrees below the horizontal. And we look for movement of the crystals. And how we do that is by looking at the eyes. So every single one of these semicircular canals, the green, the blue, and the red, connect to different eye muscles. So if I had crystals moving in this blue canal, that would trigger my medial and lateral rectus and move my eye in a horizontal beating fashion. And if I were to see that in a patient's eyes, I would know crystals are there. If crystals were in this red canal, the eyes would beat upward and you'd see a clockwise or counterclockwise torsion. And that gives us a clue that they are in the red canal. Or you have the superior canal or the anterior canal. Here you see a downward beating eye movement. So that's how we figure out where the problem lies. So here's an example. Hopefully this video is clear. This is a patient post-concussion. I am doing a right Dix-Hallpike on him. And if you look at his eyes, they started pretty still. And now they are starting to move. And it's pretty intense in the beginning and then starts to slow down. But when I analyze this, what I'm seeing is an upbeating counterclockwise torsion. And that right away tells me that he has a problem in his right posterior canal. And usually within 30 seconds, you can see those eye movements slow down and stop. The treatment for this is a particle repositioning maneuver, also known as the Epley maneuver. So the first three pictures at the top, that's the test position. If you see nystagmus or those abnormal eye movements, you go on to do D, E, and F at the bottom. We turn the head 90 degrees to the opposite side. In E here, we further rotate the head another 90 degrees. And if you look at this little clump of particles in green, you can see when the head is moving, those crystals move. And then finally, we sit the patient up. And the idea there is when we sit them up, the crystals will fall back into the utricle where they came from. Usually each of these positions is held for anywhere from 30 to 60 seconds with the patient. So it doesn't take long. Usually within 2 minutes, you can do a successful treatment. Now, sometimes patients will tell us that when I roll in bed, that's when I get my dizziness. So that's usually a clue that it's the horizontal canal that's involved. So what we do for that, that's a simple test. It's actually just rolling on your side. So here I have her rolling on her left side. And hopefully there you can see her eyes are beating, and they're beating to the left side. We call this left beating nystagmus. Now, the tricky thing with horizontal canal BPPV is you don't know what side is causing the issue here. Is it her left or is it her right? So what we want to do then, once her nystagmus settles, we'll roll her onto her right side. And we'll see what happens to her eyes in this position. And if you can make that out, that is her eyes beating much stronger in the opposite direction. So with the horizontal canal BPPV, the stronger of the eye movements is the side that's the problem. So with her, I can diagnose just looking at those videos that it's her right horizontal canal that's causing her vertigo. You can see there, the eyes have stopped. So the way we treat this. This maneuver is called the barbecue roll. So you start the patient in picture A with their head turned to the right, which is where the problem is. We hold for 30 to 60 seconds. We rotate the head 90 degrees back to the middle, 90 degrees to the opposite side. We further rotate another 90 degrees. So now we've got a 270-degree roll altogether. And then we sit the patient up, and the act of sitting should facilitate dropping those crystals back into the utricle. So there is a wealth of research on BPPV assessments and treatments, and there is very strong evidence to support these diagnostic assessments and treatment maneuvers. And the good news is usually within 1 to 3 treatments, you have an 80 to 90% success rate. But there are some caveats. So BPPV due to head injury is often more complex and difficult to treat. And there's been several studies that have looked at this phenomenon. So we know if it's BPPV post-trauma, 67% typically require multiple treatments. And that's compared to 14% who are idiopathic. Idiopathic basically means we don't know where it's come from. 25% tend to have BPPV in both sides, whereas if you just develop it on your own without head trauma, it's about 2% that will have it on both sides. You're 3 times more likely to have it in multiple canals. And in one particular study over a 22-month follow-up period, they found 57% had recurrences if they had it post-trauma versus 19% in those cases that didn't have it with trauma. So a little bit more trickier to treat, but absolutely still treatable, and we get good results with our treatments. So that's BPPV. The second most common thing we will see post-concussion is vestibular hypofunction. So the word hypofunction, hypo just means loss or lessening. So it's loss of balance activity in one or both ears. And this can be caused by temporal bone fractures, injury to the semicircular canals directly or to the utricle or saccule, or it could be a direct injury to the nerve. When patients have vestibular hypofunction, this will cause them to have dizziness, vertigo, and imbalance. And when patients come in with this particular condition, what we want to assess is their vestibular reflexes. So there's 2 major reflexes that come out of your inner ear. One is the vestibular spinal reflex, which controls your balance. And the second one is your vestibular ocular reflex, which controls gaze stability. And then treatment is targeted to allow the brain to compensate for asymmetric vestibular signals by coming up with an exercise-based program. So when I think of balance, so if a patient comes in to see me and says, I have problems with my balance, the way I think about balance is there are 3 inputs that go into the brain with regards to balanced information. Your eyes, your inner ears send vestibular information to the brain, and proprioceptive information. So that's information coming from the soles of your feet, but also your muscles and joints as well. And those 3 signals from your eyes, your ears, and your feet go into the brain. Your brain integrates and coordinates this information, and then you have an output. The output is your vestibular spinal reflex to control balance, and your vestibular ocular reflex to look at vision. So when I start with my balance assessments, I want to look at these 3 inputs and see where is the weakness in the system so that I can target my treatments. So this bit of a busy slide, I'll go over this one by one. This is a result of a posturography assessment that I would do on every patient coming in with balance issues. The first test condition here on your upper left, we have them stand on a force plate. It's a firm surface with their eyes open. So the idea there is they can use their eyes, they can use their ears, they can use their feet and control their balance. And we look at every 10 milliseconds, we're tracking how much are these patients swaying. And when we see roughly there's about 800 to 900 dots that get generated, when we see all of the dots coming together in the middle, that to me suggests perfectly normal balance, as we see in this case. Number 2, which is the one on your upper right, this is where they stand on that firm surface, but now we remove vision. So patients close their eyes. And now they're just left with their vestibular system and their ability to feel, their proprioception. And if you have 2 functioning systems, you should be able to pick up the slack. And here we see as well, there's a little bit of worsening on the balance. Generally, I would say that's pretty good too. Then we put the patients on a compliant surface. So this is an uneven surface, like you can see in the picture here, the blue mat. They stand on a compliant surface. Now they can't feel their feet as well. Their eyes are open and their ears are working. So this is a test of your vision and your vestibular system working together. And again, this patient seems to do reasonably well there too. And then the final test that they do is a vestibular only test. They're on the compliant surface. They can't feel their feet. They have to close their eyes. They can't see. And now we just force the vestibular system to work. So we can see here, the vestibular system is the weakest link here in the balance. And if I was designing an exercise-based program, I would focus specifically, in this case, on uptraining the vestibular system. So what my exercises would look like is I would want to remove the other senses, remove vision and put them on a compliant surface so they can't feel their feet. And that will preferentially challenge the vestibular system. So I might have the patient close their eyes and move their head, or maybe stand on one leg and uptrain the vestibular system. When it comes to vestibular ocular reflex, that's the other reflex that we look for when there's hypofunction. We can assess this reflex with the head impulse test clinically, or there's a lab test, the video head impulse test that can be done as well. So here you'll see I'm holding onto the patient's head. I'm going to have him stare at an object in the distance, and I'm going to rapidly move his head to one side or the other. And the instruction will be stay focused on the target in front of you. So first I'll take his head to the left, and hopefully you'll see the eyes are pretty good at staying on target. Now watch on the right. When I move the head to the right, the eyes go with the head and then quickly find their way back. So that tells me that his right vestibular ocular reflex is not working properly. There's asymmetry from side to side. And then we'll do some vestibular ocular reflex training. So usually this starts off with exercises where I'll have patients focus on targets, simple targets, and have them move their head as fast as they can, as long as they can still maintain focus on the target without that target looking blurry or going out of focus. Eventually we can move to more complex targets, and then eventually we can go to busy targets as well, or sorry, moving targets. So here she's looking at the X, but the head and the X are going in equal and opposite directions. And we do have good clinical practice guidelines for the clinicians in the audience that tell you how often and how many minutes you should be spending on these exercises. And that ranges from about 12 to 20 minutes a day. So if it's an acute situation, you need 12 minutes of exercise. But if you've had this for a long time, chronic, it should be up to 20 minutes a day of exercise. Usually it's done a minute at a time. We do 3 or 4 minutes of exercise, do that 4 or 5 times a day. And then the final one I want to talk about is visual motion sensitivity. So that's the third most common thing I will see after a concussion. So just to remind you again, balance control requires a dynamic interplay of information from your eyes, your ears, and your feet. Information is referenced to one another to maintain accurate control of your balance. So if you have inaccurate vestibular information going into the brain, that then leads to dizziness and balance issues. So what ends up happening over time, and we see this not just in patients with concussion, but patients with other vestibular issues as well, is when that vestibular information is not accurate, the brain will want to bypass that, and it will start to over-rely on vision for balance. So now your brain is over-processing your eyes for balance. This then leads to vulnerability when you're processing complex visual stimuli. So malls, grocery stores, scrolling on your screens, you start to, you're using your eyes to process that information, but you're also needing your eyes for balance, and that creates dizziness. This often then leads to anxiety in patients, and then this creates a hypervigilance towards normal visual motion that you should otherwise be able to handle quite well. And we've seen in the literature, specifically in concussions, after a concussion, the brain relies more on visual cues for balance than an able-bodied population. And if you take away those visual cues, let's say I tell the patient to close their eyes, patients after a concussion have a very hard time with balance. So this is going back to the posturography results. This is what I would see in a patient that's overusing visual information. So that first test here on the left side where their eyes are open, they're standing on a firm surface, the patient does well. The bottom left, their eyes are open, but now they're on a compliant surface, so uneven surface, but they reasonably do well as well. So when vision is there, the balance is reasonable. But on the right-hand side, the top graph here is eyes closed on a firm surface. So vision is taken away and you can see balance is much worse when the eyes are closed. And the final one at the bottom here, this is eyes closed on a compliant surface. So this is a vestibular test condition, but because the vision is removed, they are having a hard time. So this particular patient is very vision dependent. So a lot of what I'm going to do with this patient is do exercises that involve closing the eyes. So what we do from a treatment standpoint with patients that have over dominance of vision, we want to, first of all, normalize vestibular inputs. We want to then get the brain to start to use those vestibular inputs. We also may think about uptraining the proprioception, the ability to feel where you are in space. And then the big one is to downtrain your dependence on vision. Other treatments we can do is habituation. So where we gradually expose you to visual things that provoke visual symptoms and then back away, expose again. So this repeated exposure to allow the brain to adapt and build tolerance. And then we use de-escalation strategies if your symptoms are provoked. So I'll show you this graph here on the right. This comes from the Parkwood Hospital program. So basically what you want, if you have visual motion sensitivity, you want to try and keep your symptoms in the green or the yellow zone and not go into the red or significant symptom zone. So we might do some habituation exercises where we provoke some of the symptoms by having you scroll on your phone or be on your computer screen. And once you hit mild to moderate levels, we want to teach your brain how to de-escalate that symptom. So some of the de-escalation strategies I usually recommend to my patients is to close your eyes, do some surface orientation or grounding. So feel your feet on the floor, feel where you are on the chair, and try and ground yourself. Focus on breathing control, so slow, deep breaths, because a lot of times symptoms will start to change your breathing as anxiety kicks in as well. So slow, deep breathing, cognitive reframing, knowing that these symptoms are temporary, they will settle, and distraction. And once we can bring those symptoms back down, you can expose again and then de-escalate and then expose. And this helps with habituation versus if you push into the red zone where you have significant symptoms, the brain has a very hard time recovering from that and also has a hard time learning from that as well. So what is vestibular rehabilitation? We'll just sum it up with a couple of slides. I see I'm a couple of minutes over. It's an exercise-based program where the goal is to reduce vertigo and dizziness, improve your gaze stability, balance and mobility, prevent falls, and get you to normal function without your symptoms interfering. We do comprehensive assessments to try and understand the symptoms and the priorities, do clinical tests of inner ear and central vestibular function, and then evaluate balance and walking. Usual assessment for in our clinic is about 90 minutes to do all of this. Treatment is very much guided by the assessment and your goals. It's individualized and targeted, always active and exercise-based, where we focus on meaningful activities and improved function. And very much patients are all given a home exercise program that they are expected to do on a daily basis. We're not trying to regenerate a damaged balance organ or a nerve. Rather, the goal is to facilitate central nervous system compensation for the vestibular loss. We want your brain to recalibrate how it interprets these vestibular signals, and symptoms will reduce and improve through neuroplasticity. Neuroplasticity basically is the principle that your brain can make new connections and pathways. And adaptation is very much driven by movement. We are lucky to have a wealth of research papers on the effectiveness of vestibular rehabilitation. We have clinical practice guidelines and Cochrane reviews that look at high quality studies. And there is moderate to strong evidence to show vestibular rehabilitation works in both concussion and non-concussion populations. If you have dizziness, I would encourage you to consider ENT consultation or assessment with a vestibular physiotherapist. How do you find a physiotherapist? We can go over this if anyone wants in the Q&A, but essentially you want to look for a therapist that is focused on vestibular rehabilitation, or a clinic that's focused on that. You want to ask them about their experience and qualifications, ask other healthcare providers, and there's also great options for virtual care now. Last 2 slides. Sometimes even with the best vestibular physiotherapists, patients don't get better. And I just want to go over this fear avoidance model. This is adapted from Lyon and Linton. If you have an inner ear injury, this will lead to dizziness. A lot of patients that continue to move, don't have any fear or anxiety, they go on to adapt and recover. But a lot of patients, especially the ones that aren't getting better, get stuck in this cyclical pattern where dizziness leads to catastrophizing thoughts, leads to fear and avoidance behaviors, which then leads to disability, anxiety, and depression, which further fuels the dizziness. And a lot of patients can get stuck with this. And one of the things Dr. David Pothier, who's no longer with us, he developed was this concept of patients when they come in with symptoms, these symptoms are made up of 2 parts, the injury plus catastrophization. And it's the combination of the 2 that produces symptoms. So here you have patient A and B, both have the same amount of symptoms, but one person has significant injury and small catastrophization. The other one has a small injury and significant catastrophization. Yet both have the same amount of symptoms. So I hope you can appreciate patient A, we want to go pretty heavy with treatments targeting the injury, whereas patient B, we want to work on the catastrophization. If I keep doing vestibular exercises, I may not do this patient justice. This is a dizziness catastrophization scale that is accessible. It's Dr. Pothier and Dr. Repka had published this paper, and basically helps you figure out how much catastrophization might be present with your patients. So all of our patients always do this. So take home messages. Dizziness is a common symptom after concussions, and it's often accompanied by balance impairments and visual symptoms. The initial presentation of dizziness is an important clinical finding and should be evaluated with further vestibular imbalance testing. BPPV is the most common inner ear disorder, and it responds well to treatment. And if patients are not improving, I usually say within 2 or 3 vestibular rehab sessions, we may want to address any anxiety or catastrophization that might be amplifying, perpetuating the vestibular symptoms and delaying the recovery. And I encourage you to speak to your doctor if you have dizziness, or you can always contact us for a short phone consultation to see if vestibular therapy is right for your symptoms. Thank you very much for your attention. I'm happy to open it up to questions.
Great. Thank you so much, Shaleen. That was excellent. And we do have a number of questions. Just before I forget as well, I didn't mention Christian has put in a link to tonight's presentation. So that is also in the beginning of the chat, along with the link to all of our prior presentations. So let's move on to the questions. And if you do have any questions, please just enter those into the Q&A. So Shaleen, someone is saying, I've had a lot of concussions and can't get into a balance specialist until March of 2023. I can't walk down the hall without bumping into the wall. I went to the immersive Van Gogh exhibit about a month ago, and every time the slides changed, if I was standing, I almost fell over. I have no spatial perception either. Are there any exercises I can do to help improve my balance until I can see the specialist? I'm so tired of looking like I'm drunk, and I don't even drink.
Sorry to hear, that sounds terrible. And unfortunately, that's the experience of a lot of patients. And that Van Gogh exhibit, yes, it's so immersive. And for someone that's very visually dominant and over processing vision, that's going to have you're going to have a difficult time balancing with that. So I'm glad you are seeing a balance therapist at some point in time to get a proper assessment. I usually say hard to give you specific exercises without having done an assessment. I would say if there's a lot of visual stimulation that's affecting your balance, you could help reduce some of that. So periodically, let's say in that Van Gogh exhibit, I would have you close your eyes and really focus on the grounding, feeling your feet on the floor. In other places where vision is an issue, maybe putting on a baseball cap. So instead of focusing and seeing the whole space, you can narrow your focus a little bit. That can be helpful, closing the eyes. And then if there's a safe way for you to practice standing with your feet close together with your eyes closed. I usually tell patients to go right into a corner of a room and have a chair in front so that you're perfectly safe. Maybe even have someone beside you and practice balancing without the vision. And see if your brain can start to uptrain the other senses, the vestibular sense and the proprioception, which is your ability to feel where you are in space. And it sounds like that might need to be uptrained for you as well. And then I always encourage walking, because walking is 20 minutes of walking a day to be done safely, obviously. That can really help with compensation in the brain.
Great, thanks so much. Heather asks, I had the Dix-Hallpike done this summer when I had vertigo, but it didn't work. I saw my osteopath and it was, I guess they must have told her it was coming from her neck. And she's asking, does this make sense?
So excellent question. When the head is moving, so let's say I'm moving my head side to side like that, I am definitely stimulating my neck, but I'm also stimulating my inner ear. So it's sometimes hard to tell, is the problem coming from the ear or is it coming from the neck? And that's where you need to dissociate. So in a Dix-Hallpike maneuver, that's where the head is rotated and taken back 30 degrees below the horizontal. If there is BPPV, you are going to look for symptoms of vertigo and you want to see nystagmus. So you want to see those abnormal eye movements that I showed earlier. And if there is abnormal eye movements, that's coming from your vestibular system. If your head is down and you are not having that dizziness, then it may not be, it could be coming from the neck. But if there's no vertigo, then we may want to do some other assessments. The other thing I was going to say is in room light, if that's how you were tested, your brain can actually block those abnormal eye movements as well. And that's why you would have seen, I had these infrared goggles put on my patients. Darkness prevents you from being able to fixate to your eyes. And because if you fixate your eyes on a target or something, you can actually prevent that nystagmus from coming through. So I wouldn't necessarily rule it out. And then I would want to think about your symptoms. If you are having those symptoms of vertigo lasting less than 60 seconds, and they're coming on with change in position, looking up, bending over, or rolling, then possibly this could be BPPV and not the neck.
Great, thank you. Someone asked, what exercises would you give for helping with difficulty scrolling on the computer?
Yeah, so difficulty scrolling on the computer tells me that your brain is over processing vision. So a lot of times what I start to do is down train the dependence on vision for balance. So we actually start with balance exercises for these patients, doing balance exercises with the eyes closed, doing other tasks day to day, let's say washing your hands or brushing your teeth. We tend to do those with the eyes closed to down train the dependence on vision so that your other balance senses can take over some of the excess function that your vision is doing. And if we can regulate those three senses, vision, vestibular, proprioception, then that often frees up vision to be able to do visual tasks like scrolling on a screen or going into busy environments. So that's one thing I would do. The second thing I would do is some gentle habituation with de-escalation. So let's say you're scrolling and you start to develop symptoms at about mild symptoms, that could be about a 3 or 4 out of 10, I would have you stop, close your eyes and de-escalate, get those symptoms back down to 0 again. And then once you're able to do that, re-expose again. So again, close the eyes when you have symptoms, breathe, ground yourself to where you are, and just remember that symptoms are temporary so that anxiety doesn't get linked in with these symptoms, and then expose again. And hopefully over time, you'll be able to do more and more without triggering too much symptoms. It is a slow process, so these exercises don't work quickly. You want to try that over a period of a couple of weeks, and hopefully by then you start to see a dent in symptoms.
Great. Okay, thank you. Zoe asks, my vestibular symptom, nausea, often comes up delayed, so significant nausea the day after a vestibular physio assessment. Do you have an idea what might cause that delay? It's hard to do habituation when my symptoms seem to come on after the activity and not right in the moment.
Oh, no, I don't have a sense of where that could be coming from. Usually we expect to see the nausea and vomiting because your vestibular, when you activate the vestibular system, you're actually activating the emetic pathways in the brain as well, and that will give you nausea or vomiting symptoms. That's pretty much an immediate reaction. Usually don't see symptoms in a delayed fashion like that, especially not a day later. Sometimes the neck can give rise to that as well. So maybe there was too much neck movement and your neck wasn't strong enough, and that's why you're seeing some delayed effects. But I would think at the time, if you're stimulating that vestibular system and you're not having nausea, I would want to I wouldn't necessarily connect that to the vestibular system. I wonder if it could be something else.
Okay, great. Jen is asking, are there any contraindications to the Dix-Hallpike?
Yes, excellent question. So any instability in the neck, especially in the upper cervical spine. And if you are a physiotherapist, that's one of the things that you would want to check with your patients is doing a upper neck stabilization test. That would be it. Otherwise, that would be the only major contraindication. Otherwise, I would say vertebral artery dissections or vertebral artery issues would be another red flag as well, and a contraindication to putting someone in a sustained Dix-Hallpike position, because you could be blocking blood flow in that vertebral artery. You'd usually have other signs and you can test for that. Usually double vision, difficulty speaking, difficulty swallowing, dizziness as well with that, if you had a vertebral artery issue.
Great, thank you. Mary asks, can you talk a little bit about vestibular and headaches or migraines? I guess the connection between the two.
This is an emerging area of vestibular medicine right now. The connection between migraines and vestibular symptoms. There is the Barani Society has published on this, and they do give guidelines on how to diagnose vestibular migraines. Typically, what you want to see is the migraine and the dizziness occurring together. So vestibular issues are common post-concussion. Migraines are also common with or without concussion. And it's very easy for someone to want to link the two of them together, but there needs to be a temporal association. So I get a migraine and then I feel dizzy. But if you start to have episodes where migraines are occurring independent of dizziness, then I'm less likely to think that this is vestibular migraines. This is actually, if it's vestibular migraines, generally not an area for vestibular rehabilitation. You would typically see a neurologist or start with an ENT that specializes in vestibular medicine, because usually that's managed with medications and diet as well.
Great, thank you. Caitlin has two questions. If dizziness and vertigo has been untreated and present for a long time, so for example, several years, how does this impact recovery in response to treatment? And she's also wondering, this actually ties back to what you were just talking about, how to treat BPPV when there's a neck injury or pain.
Okay, so the first, sorry, Leslie, tell me the first
no
one.
problem. Sorry, I should have just gone one at a time. So the first one was, if dizziness and vertigo has been untreated and you've been living with it for a long time, and she's saying like several years, how does this impact recovery and response to treatment?
So there is actually a paper published on this, and that paper looked at time from onset of dizziness to recovery and when you should intervene. And that one paper specifically said that time from onset makes no difference. So as soon as you identify the issue, start the therapies, you can start to recover. So it doesn't make any difference whether you've had it for 3 months or 2 years. A lot of times what we find is, sorry, one other thing I was going to say with dizziness, if you have an issue, what we're trying to do is get the brain to compensate. And brain compensation can occur at any point. As soon as you start to challenge the system, you can start to compensate. So I would usually say if you've been dizzy for a couple of years, likely you're avoiding movement. And for those patients that tend to avoid movement, they tend not to compensate. And this is not just in the concussion population. We see that with patients after vestibular neuritis. So that's a virus that attacks the ear. I've had patients that laid in bed for 6 months, couldn't move. Whereas the expected recovery time should be 4 to 6 weeks after such a virus. But if you don't move, your brain has no ability to compensate. So that's the key thing. So we see patients that are chronic in our clinic all the time, and patients tend to respond well. The other thing that can be a barrier when you've had symptoms for a long time is sometimes anxiety can start to become coupled to the dizziness. And now if dizziness and anxiety start to become connected, it's very hard to break that bond. That inner ear problem or injury might have come and gone, but your dizziness now might be connected to your anxiety. And anytime you feel anxious or stressed, that in and of itself can trigger those dizzy pathways, even though the inner ear injury has come and gone. So yeah, just needs you need to be a little bit more artful in looking at patients that have had it for a long period of time, but generally, if we come at it in a multidisciplinary way where we have, like in our clinic, we've got ENT, neurology, psychiatry, physiotherapy, we all work together to try and tease out where the symptoms are coming from, why are they still perpetuating years later, and then try and solve the issue.
Great.
And then I think there's a second part,
Yeah, the second part was, how do you treat BPV if you've had a neck injury or you've got a lot of pain in your neck?
Yeah, so the Dix Hallpike, yes, does involve turning the head and really extending that head back. And that works well if there's no pain or injury in the neck. But there are other maneuvers that we do. The C.E.T.S maneuver, for instance, where the head and neck is actually kept in a fixed position. It's your body that's moved. So we can do the assessment with the head going one way, and then the treatment involves the head being fixed on the neck. So we actually don't need head and neck movements at all in those cases. So we can be creative, and there's other assessment methods and treatments as well. The most common is the Dix Hallpike and the Epley maneuver. But that's usually not a barrier for us.
Great, thank you. Stacy says, great topic and speaker. I hit a moose 5+ years ago. The mass of C1 was fractured. I have headaches and am dizzy and fall over often. I've been wearing Vox neurotechnology products, which protect me greatly. However, I know not to look up as I can fall backwards. For example, the other day I was blowing on coals to get the fire going, and upon rising, I blacked out, luckily fell into your chair. Which do you think is my issue? I will watch this one again, she says. Any comments on her? So I think she's asking what you think may be the issue with her when she is
when you fall over and black out. Yeah, I'm sorry to hear that's happened. I'm glad you've come out on the other side. Those moose injuries can be quite scary when we see the impact. Usually when I hear the word blackout, I don't think vestibular. So your vestibular system can certainly cause dizziness, but it will never cause a blackout sensation, or for that matter, a lightheaded sensation. So usually we think of maybe structures in the neck that need to be looked at if you're having, especially if it's with head motion, looking up or bending over, that you're having issues. So I would speak to the doctor about that. And if it did turn out that there was no issues within the brain or the neck that were causing your dizziness, then I'd probably want you assessed. Make sure you've had vestibular function tests that look at every single part of the inner ear to see where the issue might be arising. And if there was no red flags or contraindications, perhaps considering some vestibular physiotherapy to desensitize or habituate your ability to move your head and dissociate that from losing balance. That's probably, but it sounds like, I don't know, I guess, how much investigations you've had, but I would want you to be assessed further and look into this and see if we can figure out how to resolve this.
Great, thank you. We have a couple of questions that sort of overlap from Sandy and Crystal. So they are wondering about the duration of vestibular therapy. So Crystal says, is it normal to have patients attend vestibular therapy on a regular basis for over a year? I've heard that BPPV, it only takes 5 to 7 sessions to correct. And then Sandy was sort of asking something similar. Do we need to continue VRT indefinitely? I'm 4 years out from a traumatic brain injury. Still have dizziness, had 6 months of VRT, got much better, but it still comes and goes.
That actually worries me when I hear patients going for 4 to 6 years or even a long period of time getting vestibular rehab. This is often a private pay program everywhere. So that's a lot of money that you'd be spending. Our rule of thumb in our program is after 2 to 3 visits at the most, I need to see a change in your symptoms. And if I don't see a change in your symptoms, or at least a dent in the right direction, then I need to stop and rethink this through. Now, I have to say, I don't see patients 2 times a week or 3 times a week. Usually that's not what's required with vestibular rehab. This is brain changes that we're trying to do. We're trying to get the brain to accommodate and adapt, and that takes time. So I usually will see my patients, give them some exercises, let them go away for 2 to 3 weeks, bring them back, let them go again with a new set of exercises for 2 or 3 weeks. I'll tweak things depending on their response. But after 3 sessions, if I'm not seeing significant change, or at least maybe not significant, but a dent in the symptoms, then I would want to reevaluate. And that's where I would pull in other members of my team. Is there a mood disorder or anxiety that's preventing this brain from compensating? Are there headaches that are getting in the way of compensation? So yeah, I usually want to stop and figure out why are they not getting better? Because if you start doing the right exercises and the patient is compliant, we should expect to see positive change. And I would never see patients indefinitely. Usually on average, our patients are seeing us for 6 to 8 sessions. Sometimes we may need to put a pause halfway through if we need other interventions involved, such as anxiety management. But yeah, 6 to 8 sessions typically is what I would see, spread out over 2 to 3 weeks. Now, in a specific case of BPPV, that's a little bit different. You will do a maneuver on your patient, send them away. Usually I would tell the patients to sleep upright for a couple of days and see how they respond, and usually bring them back a week or 2 later to reassess. And again, after maybe 4 or 5 tries at BPPV at the most, I would want to stop and reevaluate, maybe get ENT consultation. If it's always one ear that's causing the issue and it keeps coming back, maybe there's some deficiencies. Vitamin D deficiencies, there's a lot of research now on that can cause recurrences of BPPV. Maybe they need a blood test. Maybe we need a surgical consult, because BPPV responds quite well to surgery as well. So this is where ENT consultation might be beneficial. Also, teaching your patients how to treat themselves. It's not rocket science to be able to fix BPPV, and you can teach patients, teach family members on how to do the maneuvers and see if they can get it better. And if it's not responding, then perhaps we need to look at something else, such as ENT consultation. I hope that answered all of that.
Thank you. We have a question. Generally speaking, how important for recovery is regular steady state exercise? For example, just getting on a stationary bike. Is there an ideal frequency?
For recovery, if we're talking about dizziness in particular, I don't like stationary bikes. So for dizziness to get better, we want the brain to recalibrate information coming from your eyes, from your ears, and from your feet. And when you're sitting on a stationary bike, you're not stimulating any of those things. So my recommendation would be is to do some steady state exercise, get the heart rate pumping, get the heart going. We know with cardiovascular exercise, you release brain-derived neurotrophic factors that help you compensate, and it helps with neuroplasticity. So my best exercise would be walking, brisk walking specifically. Vestibular patients tend to do better when they're walking faster versus slower. So I'll usually, which is great because that gets the cardio piece. I will say go for a 20-minute walk. It allows you to stimulate the ears when you're walking. Your feet are stimulated, the proprioception is stimulated, and your vision is stimulated as well. I certainly don't recommend treadmills in the early stage. Treadmills can actually increase your dizziness. So when you're walking on a treadmill, if you think of those three senses again, your vestibular system senses motion, your feet sense motion. So two senses align, but your eyes say we're not moving. And they are seeing a stationary room, and that can cause some sensory mismatch and increased dizziness. So for dizziness recovery, strong recommendation to try some walking for 20 minutes at least.
Okay, thank you.
Sorry, one more thing on
Oh,
most
yeah.
days of the week. Yeah.
Okay, excellent. I know we're almost at time, but I'm going to try and squeeze in just a couple more. We had a couple of questions basically asking Shaleen how people can get to see you or into your clinic. Any comment on that?
Absolutely. So a couple of years ago, about 3 years ago now, we did separate the vestibular rehab program. Before, it was just exclusively for patients of Dr. Repka, who's the ENT doctor in our clinic. Now it is a private pay program in the hospital. So anyone can book an appointment. You don't even need a doctor's referral to book into our clinic. So you can go to our website, www.vestibularhealth.ca. You can find more information there. Be happy to see any person suffering from dizziness and provide consultation. If you're from out of town with the pandemic, one of the good things that's come out of that is virtual consultation. And certain cases, not BPPV, but other cases are certainly very amenable to assessments and treatments virtually.
Great, thanks so much. Colleen has an interesting question. Would seniors or anyone with poor balance benefit from vestibular PT exercises, even if they haven't had a concussion? And does hearing loss correlate with balance issues?
So this is an area that I've studied with, we did a study with Dr. Carmela Tartaglia, who you may have seen early on in one of the sessions. We actually looked at seniors that were having falls and looked at whether they had vestibular issues. So we went out to falls prevention programs and did a full vestibular evaluation. Our audiologists had come out as well. So we did lab testing in their falls prevention program. And we found 83% of our patients, I think our sample size was somewhere in the 40s, 83% of them had an undiagnosed vestibular issue. And falls prevention programs in the city do not do any vestibular assessments, nor are the treatments geared to treating vestibular dysfunction or vestibular issues. So the answer is a huge yes. I think it's worth, if you're having balance issues, it's worth evaluating the three components of balance, which are vision, vestibular, proprioception, along with other things like muscle strength and range of motion, but really evaluating that vestibular system. And if there is a deficit, that is something certainly that can be uptrained and respond quite well to treatment. And one more note on falls and concussions. You don't actually need to hit your head in order to develop vestibular issues after a fall, for instance. So just that deceleration force of falling can cause crystals to dislodge in the ear and you can develop BPPV. So it doesn't have to be specifically from a head injury that you have vestibular issues. Thank you
Great.
for asking that question.
Yeah, great question. I'm going to just sneak on one last question. Lynn asks, can you explain the differences between vision therapy and vestibular therapy? Is there any overlap?
So that's a good question for last. This is a bit of a controversial area, and I'm sure if questions have come up with other speakers in our past series, this is a controversial area. There have been several papers on this, especially a couple of reviews in the last couple of years. Dr. Paul Vernelli, I think, may be speaking on this, or at least he spoke last year on this. And recently, we found a consensus paper in August 2022 in Neurology that basically said there's not a lot of evidence for vision therapy because of lack of well-designed research studies. Right now, it's mostly case reports. What I find with vision therapy, patients are given a lot of visual exercises. And that kind of goes against what I've been talking about or what we do in vestibular therapy. We believe these visual symptoms are from over-processing of vision. So now what I try and do in vestibular therapy, I'm trying to down train your dependence on vision by not by not giving you visual exercises, I'm getting you to close your eyes and do some down training. Whereas vision exercises and vision therapy, they're actually strengthening those visual pathways. So my personal preference, if someone's doing vision therapy, I don't initiate vestibular therapy at the same time because I think we've got two conflicting goals. I'm down training, they look like they're habituating and up training your vision. That's my thoughts on that. We need more research in that field to understand where that fits in with post-concussion patients. Certainly, if there's vision issues, just the last thing I want to say on this, if there is vision issues, it could be very well from a vestibular issue. We know when you have vestibular issues, your vestibular ocular reflex is affected, and that reflex helps you stabilize your vision. And if that reflex isn't working well, you can have blurred vision when your head is moving and other eye challenges. So I would always want to make sure that there is no obvious vestibular ocular reflex issue before I went and tried any treatment.
Great. Okay. Thanks so much, Shaleen. Sorry for keeping everyone a little bit long, but it was excellent presentation, and thank you all out there for the great questions. Just a reminder, there's going to be a short survey that comes your way. We really appreciate it if you can take a minute or two to fill that out and provide any feedback or suggestions that you might have. Also, we have one more webinar in 2 weeks. That'll be December the 6th at 6 p.m. We have Dr. Marie Slager, who's going to be talking about headaches that evening. So if you can join us, we'll be back in 2 weeks, and then we'll be taking a break for the holidays and resuming in January. So thanks again, Shaleen, and thanks everyone for attending. Have a good night.